Awesome. Hello, everyone. Welcome. This is the Biased Perspective on Equal Effects, AI in Healthcare. Thank you so much for joining this panel, and thank you to the panelists that we have here today. We're very excited. First, we would like to begin by acknowledging that this is a symposium taking place in Huichin, which is the ancestral territory of the Chochenyo-speaking Ohlone people. For more information about supporting their work, please see our Science, Ethics, and Policy program. Also, my name is Helena Mezgova. I'll be moderating the session today. I'm a bioethics graduate student, and I'm also an analyst with the Institutional Review Board with the UCSF. This will be a 40-minute prearranged question, 20-minute for audience questions at the end. People in attendance can ask questions through a runner with a wireless mic. People on Zoom, please put your questions in the Zoom chat. One of our volunteers will read your question out for you. Please use the Zoom chat only for virtual attendee questions. For the panel comments and other discussions should go to our SEP Slack. So it is my absolute pleasure to introduce our three panelists. Sitting next to me is Kenneth W. Goodman. Dr. Goodman is a founder and director of the University of Miami Miller School of Medicine's Institute for Bioethics and Health Policy and director of the university's ethics program. The institute has been designated a World Health Organization collaborating center in ethics and global health policy, one of 13 in the world and the only one in the United States. Dr. Goodman is a professor of medicine at the university with appointments in the Department of Philosophy, School of Nursing and Health Studies, and Department of Public Health Sciences. His research has emphasized issues in health information technology and in epidemiology and public health. His most recent book, Ethics, Medicine, and Information Technology, Intelligent Machines, and the Transformation of Healthcare, identifies and analyzes a number of issues in biomedical informatics. Sitting next to him is Dr. Jennifer James, and is an assistant professor in the Institute for Health and Aging, the Department of Social and Behavioral Sciences, and the Bioethics program at UCSF. Jen is a qualitative researcher and Black feminist scholar who conducts community-engaged research at the intersection of race, gender, and health. Her research interests include cancer, end-of-life care, patient-provider relationships, health decision-making, and reproductive justice. Her current work is focused on experiences of health and illness for people who are or have been incarcerated, as well as the ethical implications of research participation. And lastly, we have Pratyusha Ria Kalluri, and she is a PhD student at the Stanford AI Lab, quantitatively and qualitatively investigating the human concepts and social values embedded in machine learning. She is interested in ways in which we can make these aspects of medicine learning broadly interpretable and critiquable. Things that make her happy are math at midnight, radical community care, and painting. So very thankful to have these three experts here and very excited. So AI, like many other discoveries, is a tool that can be widely applied. It holds potential for strengthening healthcare in diverse communities with its capability to predict, diagnose, treat disease, manage healthcare systems, and engage research and development. However, in application, challenges arise. Since we have a diverse panel today, to begin, how is artificial intelligence relevant in your field? For example, how do you use it, research it, apply it, or regulate it? Ria, we'll begin with you.
All right. How is AI relevant in my field? So is this good? Yeah, so I'm a machine learning researcher. Before that, I worked with knowledge-based systems, like we were just talking about, back when there were still folks at the top of the field thinking about that more often. I think machine learning research means mostly trying to advance state-of-the-art algorithms, right, which means like high accuracy, usually on made-up tasks. Often tasks where the data itself is synthetic, so it's like identifying handwritten images is sort of the canonical task that machine learning researchers worked on for a long time. I don't particularly care about that research, so that is not what I personally do. I'm really interested in what it looks like to interpret these models, both the concepts inside of them and the way they shift power in the world. And that means research looking at what human concepts do these models know? Do they know primitive concepts? Do they know numbers? Do they know race? Do they know gender? And since those concepts are also human constructs, what does the machine version of that know? So I think there's lots of like interesting inspection to do there. That means both lots of mathematical and empirical work. I enjoy that work. And it's also a lot of sociology of how that shifts power in the world. Machine learning, even at the research level, has a very specific focus. And that is not interpretability, it's not equity. You can look at all this research that says all of the major ethics statements about what people would like from machine learning research and models include top and foremost things like equity and interpretability and justice, and none of those words are mentioned in any of the top research papers. This is like empirically true. So all the way at the research level to the application level, and yeah, in so many ways, I think there's these shifting of power, and I think that's the lens, and I'm so excited to be talking to both of you, because I think those applications and how they've historically marginalized very specific communities at the margins, like Black women in particular, people of color, these are topics that I care deeply about and work on and think about.
Absolutely, thank you, awesome, and thank you for being in the field. And moving into the type of work that Jen does, can you please tell us a little bit how artificial intelligence is relevant in your work?
Sure. Hi, everyone. This is exciting and weird to be in person with so many humans. I'm very not used to this yet still. It's still weird to me that AI is a part of my job. Like, I think a few years ago when I started going to conferences and people were talking about it, and I was like robots? Like, are the robots taking over? Is that what we're studying, the ethical implications of when the robots take over our lives? This is weird. Turns out that's not what AI and machine learning necessarily means, which has been good for me to learn. So as was mentioned, I do research in a couple of big areas. So I do research with and about experiences of incarceration. So that's something that I'm interested in, are the ways in which AI interacts in potentially really disturbing and troubling ways with the criminal legal system, but I actually don't do research on that side of it. Mostly AI comes in my work that's in the cancer world. So for the last 5+ years, I've been engaged in doing ELSI work, that's ethical, legal, social policy implications research on population and genetic and genomic studies. And what started out as very focused on genetic and genomic technology is now rapidly pushing towards AI and machine learning technology. So I'm really interested in understanding what are the ways as these technologies are being developed, advanced in new spaces, in spaces where they already exist, and more broadly being available to patients and providers, how can we make sure that we're considering these ethical questions from the start? How can we make sure that we're considering patient and community voices from the start as we develop these technologies, rather than sort of being reactionary and like, oh no, all these bad things happen, what do we do? Which unfortunately happens way too often with novel technologies.
Awesome, thank you so much. And thank you for having that preventative approach and mindset to these patient experiences too. And then lastly, Ken, can you please tell us how artificial intelligence is relevant to your field?
Well, it gives me a job, basically, because I get to find things wrong with it. So I'm a philosopher, although in the interest of full disclosure, I should mention that some years ago I worked in an AI lab. It was a machine translation laboratory. And there I learned some of the foundations of, well, things including software engineering ethics. And what has occurred to me as a philosopher who runs an ethics institute at a university is that there's an opportunity here, both a teaching moment and a research moment, not both. If there are three things, you don't say both, you say what? There's a word missing in English we've just discovered. So for these three things, teaching, learning, and making the world a little bit better, that artificial intelligence has for some time been an exciting opportunity. We've discovered, for example, in the context of healthcare, many of our compatriots have comparatively poor health literacy. How many ordinary people have high information technology literacy? And I worry about that too. When we're concerned about bias and discrimination and a lack of equity, what you would hope for from your new technologies is that they wouldn't make any of them worse. So for example, for those, I'm having the awful feeling I'm the oldest one in the room. But for those of you who remember Microsoft, when it actually started selling software, well, you all use Microsoft Access databases or have. You can have bias, and you could have had it 40 years ago in an ordinary database without anybody intending to be biased. When you fast forward to our year, and the excitement that has been engendered in science, in society, in commerce around artificial intelligence, what I think there is an opportunity, a rare opportunity, to try and get it right before we make too much of a hash of it, which we have done in the past with other technologies. So for example, and apropos the work you two guys are doing, what will it matter if a technology, what will it matter if a technology improves healthcare, improves genomics, includes clinical care, includes public health, includes biomedical research, if, for example, it leads to another generation of drugs and devices that not everyone can afford? One of the points that I've tried to make about AI, and this may come up again in a second, so I don't know if I'm leading the runner too much here, but to make a point very briefly, and in hopes that you will agree, if ordinary computing, if ordinary databases, if artificial intelligence training sets are biased, and we think they are, we ought not to be under the illusion that fixing our data sets is going to change your society. The reason they're biased is not because a bunch of racists were writing code. The reason they're biased is because we have a racist society. The reason that they don't incorporate the role of women adequately is because we still haven't included women adequately in human subjects research. The reason that if you have a disability, it's not going to solve your problem is because we've done a really bad job in our country providing adequate accommodations for people with disabilities. That's not AI's fault. But we surely want to make sure that this next generation of science doesn't make things worse. And that makes it, I think, a really exciting opportunity for you, for us.
Absolutely, absolutely. Thanks, Ken. And yes, you did segue perfectly in some of the next notes that we're going to cover. And this could be open to any of the speakers. To decrease bias in AI's detection capabilities, increasing size and diversity of data trained on is very important. How doable is this right now? Human supervision is still very much needed to do this. Do we have enough experts to do supervision to ensure robustness, or does it help to diversify the medical experts to begin with? Jen, do you have any feedback on this?
I mean, yes, we should diversify medical experts. That's an easy first answer. That's always a good thing. I mean, I think, and this goes to what Ken was saying as well, I'm concerned, I mean, bias exists across all data that we have. And I think my concern is that we haven't figured out how to ask the right questions on a really basic level yet. If we just look at things like race and gender, we don't assess those well in our medical care, right? So when we're asking information about race, we know that race is a socially constructed category, not a biological one, but then we apply it biologically. We haven't gotten to a point where we can say, what are we really looking at? Are we asking about this because they're concerned about skin color and melanin level? Is it a concern about ancestry, genetic ancestry? Is it a concern about socioeconomic status and neighborhood, about immigration status, about what race your grandparents were? Is it, we don't know yet. And same thing with gender. Is it about your chromosomes? Is it about the organs you have? Is it about if you've gone through puberty? Is it if you're socialized this way as a woman? Is it about experiences of racism and sexism, both interpersonal and structural. We don't assess any of that. We only ask really basic questions, which then get fed into, the clinical algorithms that are already in existence. They get fed into how our clinicians view us in the clinic, and then just keep getting replicated. So science, played a really critical role in establishing these categories and establishing race, right, which perpetuated racism in our society. And the way we use them in clinic just perpetuates it further, both through widening health disparities, as well as through the biologicalization of some of these categories that we know aren't truly biological. So I think my worry is there a way, can we intervene on that? Can we intervene at the point of what is the data we're collecting and what are we doing with it? Now, before we get even further, even deeper into developing technologies that are so grounded in data we know is flawed.
Absolutely. And Jen, if I could still pick your brain just a little bit, because we're on a train of thought that segues into the work that you do with clinical populations. How well educated would you say that people are in the informed consent process when they're knowing that artificial intelligence or these emerging technologies will be used? How are their perceptions to this?
Yeah. So, I think this is something we're still learning about. There's been studies about this that have come out in the last few years. How do people feel? What's their perception about these technologies? And I feel like most of them are positive. People are fine with it. But I think there's a lot we don't know about that. I think there's a couple things. One is, how does this vary across sort of disease spaces? Is it different if we're talking about prevention versus intervening for something that's really complex? Does it matter if it comes from your doctor that you know and have a relationship with versus in the context of a research study versus something, versus a direct-to-consumer company? And then, just on the topic of consent, did the people who agreed read the consent form ahead of time and understand it? We know that people tend to not do that. People can't tell you most things about a consent form if you're not doing sort of really teach back, really in, highly engaged forms of consent, which are still not always the norm. We have more and more studies that are enrolling people online where they don't get any form of that. So I think we don't necessarily know. And I also think that there's some things here that are methodologically really tricky that I think about as a qualitative researcher. So if I ask you, what do you think about AI? That's, first a hard question to answer, because again, it's you mean robots? Do people know what that means when you ask them what they think about it? Versus am I asking you about, what did you think about this healthcare experience you had that you've already had an outcome for? Would you recommend this to somebody else? Versus what would you do if you were given information from an AI source? And then again, does it come from your doctor or not? So I think, there's a lot, we need more data, more robust data, better understanding of what patients think when they make these types of decisions. But I think what I worry about is that oftentimes when we talk about patient understanding in this context, it's always sort of as if patients are a barrier to advancing the technology. It's not, how do we make sure that patient voices, needs, preferences are centered in the development of these technologies? It's how do we make sure that people will agree to this so we can get enough data so we can do the things we want to do. So I think making sure we have a sort of a fundamental shift in how we approach the value or the need for engaging with patients through this development, and not just overcoming the barrier that is people are worried about privacy, which, are we that worried about privacy? The internet knows everything about us. The data doesn't show that we actually are worried about privacy. So.
Absolutely, thank you. And I think these advocacy groups and patient advocates should be, establishing more trust in the system too, so that can deliver, more models. And Ria, this question is directed towards you. Since AI models are working off of these historical data sets full of bias, what methods do you use in your work to ensure their predictions for future use aren't full of bias as well? And what are some strategies that perhaps either you're doing in your work or your organization or the things that you're part of is doing that too?
Yeah, I think I would start by asking all of us to challenge the idea that the problem or the race problem with AI is the word bias. I don't know that bias is always the right word or the right concept. When you ask researchers, academics, machine learning researchers, doctors about the bias in machine learning models, it's kind of gets around a lot of the important issues, right? It allows people to be like, well, garbage in, garbage out is one of the most common phrases about this, that ML researchers, people applying it, doctors, all these people say, well, it's just the data, garbage in, garbage out. I'm a good doctor, I'm a good researcher, the model is good, just someone got the wrong data and they should fix that, right? And bias allows you to say that in some ways, and there's context for sure in which it's useful, but it's very different to ask people about equity and justice. Equity and justice say bias is not something that is, someone else has just put a little bit of it in here. Justice is not this isolated technology having something that we don't want it to have or is different than the norm. Equity and justice is, well, there are historical traditions of marginalizing certain peoples. Are your models reproducing that? Are you using your models in ways that reproduce that? It doesn't really, bias is so strange of a concept here. Because, for example, if you use your machine learning model and you use it to increase surveillance, right? You do a better job of tracking criminals. You write criminals. Yes, I'm using this as like the thing that I don't agree with, but that's fine. So if you use it for surveillance, the fact that you've minimized the bias and made it good at identifying black men and not just identifying white men, it's absurd to call that like fixing the bias, right? Because the model is used for like bias in the world, for lack of justice, for lack of equity. So I think we should like really challenge ourselves and question ourselves of saying, okay, this isn't a bias problem, it's a justice problem, it's an equity problem. And that also forces you as an individual to not just read the bias literature, which in some ways is relatively newer and academic, but it forces you to read the justice traditions, the equity traditions of these people doing, justice work for decades and decades, including a lot of abolitionist work that people just get to avoid when you ask them, well, have you fixed that bias problem with your like health machine learning model? So I think that's one of the biggest things I will say about this. I think with that in mind, the garbage in, garbage out problem, one, it seems like it's not the whole problem at all, based on everything I've said. It's also not a problem that has like the idea that it's a simple problem, there's a simple fix. Well, I've said it's not a simple problem. There's also not a simple fix, right? The idea that if you get better data, then you will fix the problem and we just have to do a better job. That also, when you see it from a bias perspective, you're like, great, I'll get more data of like people of color who are not in the data set. I will get more data of trans folks who are not, well studied for a specific health application, and that'll fix the bias problem, right? But there's a lot of issues here when you ask the same question about justice. One being that getting data, like this phrase getting data that we sort of get to say neatly when we talk about bias, is really, really complicated, and it is not, very often it is not in line with equity. Getting data is traditionally a hugely extractive system. Data is sort of this artifact, this entity, and people get to take it about you, usually without you, right? You don't have to give consent for a lot of things, just like in the world. We sort of try to come up with different ways of imposing like promises that your consent matters. But people can sort of do all of these things to get around your consent. And that strikes this really tricky, like, there's a really tricky thing to think about with getting more data. Because on one hand, getting data about underserved communities, our communities' issues, right? So, for example, like Black mother mortality rates were historically completely ignored, right? Like not well studied. This is also true of like women's like reproductive health matters, right? These are hugely understudied, and it's because no one at a research institute can say like, here's the data, now let me work on it and like solve problems. So that is true. And when people often, like women historically, or non-binary folks, did the work themselves to say like, okay, let's all put together our own personal data of people we know who have gone through decades of illness or died after birth or had, endometriosis for decades. Like, let's meet on like the internet. Let's talk to each other. Let's try to collect a data set. Well, that actually did help, right? It made it so that this data was a thing, an artifact that people could then point to and try to shift policies around, try to challenge their doctors around, right? So there's that version of data collection. And there's also the understanding that, well, data is usually extractive. Moreover, if you are the only trans person in a data set, if you are the only Black woman or person of color in the data set, it's extremely easy to identify huge amounts of information about you. So if I create this nice little data set, and this is, a very non-hypothetical example, it's probably very common, right, which is a health system, a doctor's office, a hospital says, great, some of these issues are understudied, we're gonna take this data set, we're gonna anonymize it as much as possible, we're gonna delete all the names, the identifiable information, and now we're gonna maybe create fake names so it's still a nice data set looking, and we're gonna hand it off to Stanford researchers, and they're gonna study cancer in this data set, and how these clinical trials go, and they're going to be especially interested in how this affects underserved populations, right? Well, once that data set's out there, if you get like 2 data points about an individual, right? If you get the fact that they're an indigenous person and they also live in the zip code, 02 whatever, you can identify them. So now like everyone publicly has the information about their entire medical history in this public anonymized data set.
Absolutely, yeah. Thank you so much for bringing up that wonderful point. And I want to give Ken an opportunity to speak on some of the issues that both Jen and you, Rhea, brought up to say if you have any further comments, and then perhaps also segue into this issue of privacy and liability that you brought up, Rhea. So Ken, any thoughts about what was just mentioned, and then also what are some of the privacy and liability concerns of artificial intelligence and its accountability?
That's a lot of questions.
That's a lot. Okay, maybe let's just discuss the privacy part.
Fortunately, at least for, let's pretend there's an entity called the ethics community on Earth. We're here in the North American ethics community. We work with our colleagues across the country and across other countries too, North America, including several other countries. This is not our first rodeo. We have a new technology that we're not developing for what's the technical phrase, shits and giggles. We're doing it because we actually think that it will improve the health of populations. If an appropriately conceived, written, and deployed information system that uses algorithms, either the newest back propagation algorithms or the kind of algorithms that used to be knowledge-based systems, there's evidence that they will help in hospitals make more accurate decisions than humans. There's a reason to believe that when it comes to public health, they will be able to predict better than humans. So let's say we've got the problem that you've shaped is a really interesting one, because on the one hand, we have a technology we want to use to serve goals which I assume are uncontroversial, namely improve public health, construed really quite broadly. On the other hand, we're worried about who wrote the software, who's going to be using it, is that use appropriate, and what are the kinds of consequences of not getting it right. And so, as I said, it's not the first time we've tried to grapple with this. One of the points I think that's coming out, the thread that's coming out of this is that we have an opportunity to figure out what are the issues. Well, ELSI, it's our favorite acronym, ethical, legal, social implications. It began in the Human Genome Program, and some of us are trying to apply it now in information technology. We want to get this right. And the impediments to us getting it right are, as you've heard, sometimes the data sets are sloppy. We'd love to be able to make better use of electronic health records, except most of the notes that our colleagues write in hospitals are really not very well written. And we also have a society where you get your health care through your employer or through the government, depending on whether you meet Medicare or Medicaid standards. But in my home country, by which I mean Florida, where the legislature regularly tries to figure out how little it can do to support Medicaid, And by the way, we're a room full of people wearing masks. I can't tell you how happy I am to be here with civil people who do not articulate a liberty interest in making others sick. I don't know how that evolved in Florida, but nevertheless, they let me out to say that sort of thing. In other words, the values that shape our society are going to shape our healthcare and the development of the technologies we use to improve it. And by the way, healthcare, well, is large and affects everyone, but we're also worried about transportation and the environment and issues in civil society like the treatment of prisoners, for instance. And the tools and the databases that we're creating, I think if we get it right, bid fair to help us do all this better. So the ethics community in the last couple of years has gotten excited about AI. Some of us have been trying to say these issues have been around for a long time, but that's okay. If it takes fears of robots to get people interested, I'm okay with that. We want to make sure these systems are transparent. We want to make sure we can explain them or try to understand them better. We need to make sure they're adequately governed. We need to know what privacy mechanisms are in place to make sure they're used appropriately. We need to know whether and to what extent humans need to be in the loop. An autonomous AI system in a hospital that does not have human intervention, are you okay with that? The answer is you might be if research shows that you get better outcomes. So in some sense, the secret answer to all of this is we need to support you all doing more studies of how to develop these systems, how to run them, how to identify appropriate uses, and how to govern them. And that, I think, transitions into the question of privacy. How many people in the room have ever, you're online and you want to buy something, and you see a screen full of disclosures for privacy. How many of you all, but can we just say this is all in private now? Like this is what happens in this room stays in this room, okay? It's being recorded. Sorry. Never mind then.
Verbal consent.
How many of you all have clicked and said, I accept, without reading the entire document?
Every single one.
So one of my concerns about health privacy is I and you have regularly clicked the okay, yes, or WTF button, but we know that the clickstream is gathering information about us when we do it. And we know the people gathering that information are using it to sell to each other, are using it to improve their products, are using it to do all sorts of things. And we shrug and say, yep, well, that's the way the world is. And then you come to people and you say, we'd like to use your de-identified health information to improve the health of populations. And they shrink back and say, well, what about my privacy? I say, you've given it up to Google and Microsoft already. Why don't you want to give it to the Department of Health for the state of California? Which, by the way, I think to this day still has different values than Google and Microsoft, right? We hope. In other words, we've been very selective in the kinds of things that we are offended by. I want to be able to say that for example, if the Department of Health of the state of California wants information about me, my answer is, of course. I've benefited from information about other people, and I don't know who they are. So therefore, I have a duty to contribute to that store of information. Assuming, of course, the people who use it are using it in ways we've identified, or we're trying to identify here as minimal conditions for use of information technology, but also designing a healthcare system. Stop producing unjust systems. That's a really good beginning. I'm with whether bias is the right concept or not, it's an interesting idea. But at the end of the day, our new technologies are working in communities that are already wobbling in terms of civil society. And by the way, the United States of America has 50 little countries. In my little country, it's against the law to ask someone if they're vaccinated to go to a public event. The Department of Health in Florida is run by the Proud Boys. It is an embarrassment, and yet that's what some of our compatriots think is acceptable. Our challenge, by the way, we're having far more policy fun here than they are on the West Side. Our challenge for ethics and policy is to manage that kind of division in our country, where some people actually will say that they have no duties to each other. It's all liberties. And I think that's a fundamental, and has long been recognized as a fundamental ethical mistake.
Thank you so much. And also to add a little bit of insight, in June 2021, the WHO developed guidance on the ethics and governance of artificial intelligence for health, and Ken worked in collaboration with this. And just to summarize the key ethical principles for use of artificial intelligence for health, I'll just quickly say them. It's to protect autonomy was one of them, promote human well-being, human safety and public interest, ensure transparency, explainability and intelligibility, foster responsibility and accountability, ensure inclusiveness and equity, promote artificial intelligence that is responsible and sustainable. So we can see how the discussion today has hit on some of those points, but of course we can deep dive into each of those just a little bit more. And I did want to propose this next question to anybody that would like to answer it. When discussing AI accountability, which Ken touched a little bit upon, who should be held responsible? Should it be the medical team, the algorithm designers, or the machine itself? Or can it be all of those? And can you provide any examples? Opening it up to whoever would like to answer.
Are there any lawyers in the room? The reason I ask is if something goes wrong with a computer, it's not entirely clear who you would sue. Would you sue under the theory of liability, namely the product didn't work the way it was supposed to, which means whoever wrote the software, built the gadget, or plugged it in may be the one you'd sue? Or is it negligence because somebody should have known that there was something wrong in the system? And those are the two kinds of ways you sue in our system. The question itself suggests a really broad new view we need of accountability and responsibility. What a lawyer would actually probably do is sue everybody. But that doesn't get us to the problem of who actually ought to be held accountable. And getting it right might mean, well, in human subjects, are human subjects, wouldn't it be nice if human subjects governance in the United States was developed because we just wanted to get it right and we didn't want to treat, we wanted to make sure that people's rights were protected? In fact, it comes out of what?
It's responding to all the atrocities, the things we did horribly.
Well, right. Everybody, how many y'all are familiar with IRBs and human subjects protection, at least a little? There's a mechanism in place for that. It didn't come because a bunch of philosophers and other boffins said, how are we going to get this right? It came out of Nuremberg and Tuskegee.
Yep.
And that's a problem that we still have yet to overcome.
Reactive instead of proactive, and shifting to the work that Jen is doing, trying to be preventative in this. And do you have anything else to add about the accountability?
Yeah, I mean, I think it's such a tough question, and I'm not a lawyer, and I know these are things that are like being adjudicated now with like self-driving cars. I mean, I think we're starting to figure out what the rules are going to be maybe on some of this. But I think, I mean, linking it back to some of Ria's points, I think it gets to this question of like, are we making these technologies just a set of like, there was just bad data and we can blame that? Or are we sort of taking responsibility and saying, what is the goal of this technology, and and does the person who is engaging with it have a responsibility or an understanding of this? So I think this speaks to, you know, how are we engaging providers in the development of these technologies? Are they being sort of told top down, this is the new guideline, this is the new tool that you use, and or are they being engaged in the process of developing, this is how we could use this tool to advance health, this is the way in which it advances health and for whom, how is this driven with an equity lens in mind? Like, I think that there's some that has to be, I don't know, I struggle with questions. I think we have to, of course, grapple with the questions of things like medical negligence and medical malpractice and what happens when something goes wrong. But I think we also need to consider the flip side and, you know, what is the purpose of engaging a new technology? What is the goal that it has? And what are the roles of all the people who are surrounding it? Because it'll never happen in isolation, right? You're going to go into a doctor's office, into a hospital, you're going to give someone a sample of something, like there's going to be a person involved on some level somewhere who's even just explaining to you what the process is, who hands you the consent form. So I think making sure, how do we engage all of those people is really a crucial step. And then the other piece I just wanted to think about, which gets to this reactionary piece as well, is, I mean, there's just going to be so many uses for these technology that we cannot begin to anticipate. We don't know what it's going to be yet. And that's sort of, I mean, the long history that we have, right? And we've seen, you know, when in the 80s and 90s and 2000s and people were doing gamete donation, it didn't occur to anybody that you'd have your entire genome sequenced for like $200 and it would be on the internet for anyone to find, right? No, it didn't occur to anybody. And then when everyone started paying $200 to have their entire genome sequenced, or, it didn't occur that like, oh, that'll be able to be used so that, if you're white in this country, we can figure out if anyone you're related to has done a crime ever. Like that we didn't know that would happen. So I think when we think about when people consent to technology, when we deploy new technology, whose responsibility is it to think about the unintended consequences? What role should that play in our decision that this seems like it'll advance health, but it involves collecting this type of data, which is stored in this type of way, which is used by these direct-to-consumer companies that Google can use in this way? Who should be involved in making those kind of decisions? How do we, and whose voices do we prioritize in thinking about what might this do that we're not thinking about, in addition to like what happens if something goes wrong with this really small use case that we have for this technology?
I'll add a few words. I think that's so right. Yeah, I second so much of it. Picking on a few aspects of what we just mentioned. So one thing that you were just mentioning is, well, this question sort of started with like, oh, who's accountable? And maybe a very important question that doesn't always receive the same amount of attention is like, who are you accountable to, right? Yes, there's, some people might ask the question of like, oh, who should be punished? But maybe that's not the point, right? Like, from a justice perspective, that's often not the point. We're interested in like restorative justice. We're interested in accountability. Doesn't mean like suing someone. Accountability means creating a restorative, transformative like scenario, right? We want to shift this, and well, how do we want to shift it? Who do we want to shift it for? I mean, if you really ask that question, people have to confront the answer. Who are they protecting? And I think for probably several of us on the panel, for probably a lot of communities who have been pushed to the margins, the answer is we need to be accountable to the most marginalized peoples being influenced by the system. That's huge. Just saying that, right, bringing that into conversations of accountability seems kind of rare, much rarer than it should. And that question of accountability being about getting something, not like getting your researchers' need, not punishing someone, and the people being the communities at the margins, well then different decisions get made, right? So an example of this is even this concept of privacy. It's interesting because we can sort of say, well, privacy, there's sort of the trick people say, one of the big tricks that have been played on the world is to convince people that privacy is an individual right, not a collective right. This is interesting, right? All of us as individuals have sort of been convinced by society that like, do I care about my privacy? And I can say yes or no, and I can like talk about the trade-offs, but privacy is a big collective good. And there's a lot to think about there because it both means that, well, by giving information to the right people, maybe I can sort of help us shape data, help us better understand trends. But the opposite is so true, that if I say, well, I don't care about my privacy, so I'm going to use all of these systems. I'm going to allow the government to take my data when I go, to certain government like offices. I'm going to let the grocery store take my data so I can use sort of the convenient platforms they have for like buying things quickly. That means the people who can't afford that lack of privacy don't get to opt out of the system anymore, right? Because the government says, well, if you opt out of this, everyone else has opted in. So we have a fully functioning system. If you opt out, you're not going to get like food stamps. You're not going to get this government support. These are huge things. So I think we, again, have to hold that thing of continually asking our question of, okay, who are we accountable to? The most marginalized person. So when we build this thing, when we say, this is our privacy system for this place, or this is our health object, our model we're using, well, how is it influencing the most marginalized person? I think we make very different decisions.
Can I add one thing? That's really fascinating and important. And I think the other thing I'm thinking about with that is I think we don't always remember that people's risk calculations around that are really different. Like we make it a matter of like trust or not, like why don't certain groups trust whatever, XYZ, without realizing that like people who are marginalized have very different risk calculations and like what risks they can take, what privacy, what things are allowable, what systems they have to engage with, they get to engage with, which is really important. And I also think, and this links to something Ken was saying as well, it's so challenging to think about how we make decisions about, when we freely give away privacy, or different aspects of our data. And I think that there's like two things. Like one is like, does science or government or whomever is collecting like sort of health data for a good, do a good enough job communicating about why that's necessary versus, like I think if I click terms for Google, like I'm like, okay, I need an email address. This is going to give it to me. I need to be able to go onto Google Docs. Like it feels like this is something I have to do. And similarly, if I go into the hospital and I'm in the emergency room, I sign the paper and I give them all these rights that I also don't read because I like need care. My leg's broken, fix it, right? What are we doing to convince people, or how have we demonstrated this is why your data is used, this is why it's a benefit to you and your community? But then I do think it speaks to this idea of like our very individualistic approach to health. Like I think countries that have national health systems have very different relationships with the sharing of data broadly for the benefit of others. And first in our country we just like don't have like one place where we put health information, which is a problem. And I mean that's a whole other conversation. How do we get all our data together and the challenges of doing that? But I mean, which I think speaks to this as well, but we have a very like, I get my own health insurance, I go to my doctor, like we saw with the pandemic, the idea of public health and that health is something we do collectively is really, really challenged. So I think thinking to how to, that seems like a big problem that we need to address like first before we get into these conversations about how do people make individual privacy decisions when we haven't we don't have this large scale investment in health and health information as a public good. And we don't have adequate ways of entangling how people make decisions about what's risky and what's not and what makes sense and who they can trust. I think our conversations about that are still so limited.
And that's a really important point. Why would I give you my information if it's not going to build a system that I'm going to be able to participate in?
Yeah.
That's been the greatest challenge that we've faced. We keep saying to people, I keep saying to people, you have this duty to the community to share information. But the perfect response to that is my duty to share information needs to be mirrored by a society that's going to take care of me when I get sick. And right now, we don't do a very good job of that. That's why, did you have a question coming up on data ownership? Did I remember that? Or because one of the things you Americans keep wanting to do is own data. I don't know how you can own data or own ideas. Everything becomes property here, as opposed to what the real issue should be, I think, would be control. There are people who want to use NFTs or non-fungible tokens so individual patients can control how their data is used in different settings. So, okay, for this critical use, okay, for that research, maybe they'll pay for public health. But I think part of the problem is again, self-inflicted. We keep wanting to own things, and that's going to make it difficult to build a system that's responsive and just in the way I think that we really, really want.
I'm barely starting to understand AIs. We can't bring NFTs into this conversation because I can't, no.
That's a panel for another conference, right? And I think this, even putting it into perspective of, we speak about this from a developed nation's perspective, but we haven't even begun to discuss the issue of justice in developing nations and how AI will be deployed there. But also being very mindful of the fact that, we have to open this conversation up to questions and answers from the audience. Although this has been absolutely wonderful, I would like to just ask one more question, because many of us might be sitting here thinking, how relevant is this to us now? How widespread is the current use of AI technology in healthcare? And how far along are we from the full deployment of it? 5 years, 10 years, 50 years? And perhaps just a quick question before we open it up to the audience too.
Rhea knows the answer.
Yeah, you know the answer.
How relevant is this?
Or how worried should we be?
So it's already here. There isn't a future thing. There is one, yes, you use machine learning models constantly. Like all of us are influenced by machine learning models all the time. By healthcare systems, by policing systems, by like any corporation we interact with tracks our purchasing history. So that's here, that's one answer. The idea of like 10, 15, 50 years, like that's a question people have asked as kind of like a cute question at the biggest machine learning research conferences for decades. Like since AI was at the first AI conference, people were having that question of like, oh, is it 5, 10, or 50 years? And these days, you know, at these like kind of big machine learning research conferences, there are niche people who are like, okay, like AI, when is AI going to get big? Like, when is it going to become general intelligence? And they vote on it, right? And they're like, is it 5, 10, or 50 years? And I think the answer is partially like, there isn't some other thing on the horizon. There is machine learning here, right now, and it is continuing to evolve. So we should all care a lot. We should care right now. We should care in part because, you know, this question of 5, 10, 50 years also kind of follows this strain of thinking that technology is this like inevitable thing that's ongoing in this progress, and it's just this line, and we sort of have to deal with what comes out of it, and technology is not inevitable. It's incredibly contingent. And I'm going to take a minute to say this. Is that okay? Can I take...
We consent. I consent on behalf of everyone.
I'm taking my time. Yeah, I think just to name this contingency for everyone, machine learning models, like there is a world in which one of the primary things we care about when we talk about machine learning is that you can delete your data from the model. This is a world, right? That's an interesting question. It's socially interesting. It's mathematically interesting. It's a really interesting question, and people don't work on it, right? It's very, very rare to work on this topic. People don't work on the types, right? Like instead, machine learning model is seen as this thing that, well, once you put your data into the model, we can extract everything about you, right? You don't say your race, but you say your neighborhood. We can extract your race, and so it is. I'm sorry, but that's how models work. Well, that's not how models have to work. That's what we've chosen to work on. All of the values that you mentioned in like Ken's proposition of these important values, again, none of them are listed in the top, right? Like we did this analysis of the top machine learning research papers. None of them are listed, despite the talks about AI being really excited about them. So everything is extremely contingent. People are working on tech interests. Historically, before that, they were working on Department of Defense interests. But you can imagine machine learning and AI models that are just wildly different. Yeah, where you can delete your data, you can see into it, you can hold it accountable, you can critique it, and you should empower yourself to imagine all of that. And that's another reason to care, is because it's not just a thing you have to watch, like you get to imagine a different version of it.
Thank you. I wish we had another hour on this panel. Also, just opening this up to any questions that the audience may have, or any questions on Zoom. Now's the time.
Sure, I have a question from our Zoom participant, Anand Rao, who asks, to what extent do you think the regulations, for example, the EU's AI Act, can help in addressing some of the ethical issues? Do you think our regulations should be risk-based, or should we ban some uses of AI until we have done more research on the ethical issues of its use? If so, what are the specific uses of AI in healthcare that you would ban? For example, autonomous surgery.
Would anyone like to take a stab at that?
You didn't say they'd be hard questions. So remember, ethics precedes the law. We wouldn't know what to require or forbid in civil society if we didn't have a pretty good sense of what was right or wrong in the first place. When it comes to regulation of the sort you described, there are different ways that we can regulate ourselves. Industry sometimes, although not always, regulates itself, sometimes inadequately. Sometimes professional societies and organizations do. I mean, the regulation of the medical profession is for the most part not done by government. It's done by professional societies that credential and accredit and require certain educational things. And it's something similar has been proposed for information technology. In fact, IRB-like mechanisms to look at software. Is this safe? Is it effective? You don't need to look, the government would not need to look at millions of lines of code in order to find out if it was okay, as much as there, by some oversight mechanism, make sure that it's functioning as intended and that those intentions are in fact the right ones. We live in a country where we've commodified all kinds of things, and it makes it more challenging. Our healthcare system is a challenge, unlike others, because people know that if they get sick, they're going to get health care. In this country, you're afraid that if you get sick, you might not. And artificial intelligence would be the last thing you're hoping for, depending on what's gone wrong with you. What the EU is trying to do, and some of the newest EU privacy regulations, data protection, are really quite interesting in healthcare. We'll read up on them. They've only been out for a month. But it's an attempt to try and say, here's what we're going to require of each other in order to protect shared values. I don't mind government regulation as long as it's the right government, you see. 4 years ago, I would have trembled at it. Right now, I might be better about that. But once again, in our country, and for that matter, for our Canadian friends, there are lots of little states and provinces, and they have a great deal of autonomy, which makes it really quite challenging. In Europe, they've actually tried to undo some of the effects of 27 individual governments, because it's hard to get agreement in those contexts. There's still room for some autonomy, I guess, if you will. But what I want to say is, for colleagues like we have here, it's their job to help us get this right. And that academics and the advocacy communities, including, by the way, we don't mention enough, but the disability community has a real opportunity here to say, here's why we want this technology, and here are ways we think we can use it to get things right.
I'll just add on and say, it feels hard to talk about banning or stopping AI because, as Ria said, it's so big, it's so ubiquitous, it's already here, and there's ways that, like voice to text technologies that are, that's used in healthcare, can save a lot of time. There's different forms of AI. So the idea of autonomous surgeries, that just freaks me out personally. Like, I kind of want a human in the room if I'm being operated on, but that might be me, and others might feel differently. But what I think is important is that, first of all, we can't do like an international ban on the advancement of new technology. So no matter what we decided here in the US or in the healthcare space, these things are the technology is gonna continue to advance in direct-to-consumer spaces, in other countries or other regions that have different ethics and different regulatory spaces, and that worries me too. I think we need to do it in ways, with collaborations between ethicists and computational scientists and medical sciences and whoever else needs to be in the room, with patient and community voices in the room. And I really think the more we can sort of strengthen the value we put on patient perspectives, community perspectives, and ethical perspectives, the better. I spent a lot of time being in a room where I'm the only ethicist, the only social scientist, sometimes the only person of color, and I'm raising these concerns and met with eye rolls, and I'm not, because I don't have a specific type of knowledge, my contributions aren't viewed the same way. That's something that we can change. That's a culture that exists in academic medicine and certain spaces that we need to speak to. But I think if we can work on these in a way that's thoughtful, I think slowing down and and being okay with it, not just having a race to whatever is useful, but if we can have thoughtful conversations about how to do this, that's more ideal to me than banning it in one context where it's just going to go sort of in the wild without those types of thoughtful measures.
Thank you. And do we have another question?
Hi, I was wondering if you could talk a little bit more about explainability in AI models, especially in the context of healthcare, and I'm curious whether for healthcare AI, is explainability any more important than it might be for other types of technologies?
I have really mixed feelings on this for a few reasons. So, I think explainability as a concept sounds good, sounds important, is a value. I think there's a couple things, which is explainability, by whom and for whom. So does someone need to be able to understand and explain it, or do patients or providers need to be able to understand it? As a patient, as a consumer, there's tons of technologies. I can't tell you how an MRI works. I can't tell you how a blood pressure cuff works. I don't know what it means. I don't know why it's picked. I don't know why it's selected. But if my doctor says this is based on the evidence, I just believe them. So I think sometimes we make it that something has to be understood by everybody, with novel technologies the way we haven't with a million other things that we use every single day. It's so weird to me that this idea that there's a black box that no one can explain, the person who developed the model or developed the machine, whatever, can't explain how it works is weird to me. But at the same time, we have, the mind is a black box. We can't explain how so many decisions are made in healthcare. And in some ways it seems like there's more opportunity to intervene or to think about it critically in something like AI, where we sort of acknowledge things that can't be explained, excuse me, versus the many other places in healthcare where we just sort of ignore that a little bit. So.
One thing that's worth remembering is that there are several different flavors of AI. Some algorithms, when they learn by making mistakes really quickly and repetitively, are the ones that have captured people's attention a great deal most recently. They're the ones that have learned how to play the game Go. They're the ones who've discovered how proteins fold. They're the ones that radiologists and dermatologists and ophthalmologists and pathologists have gotten really excited about. But if you try and get ordinary language, the kind of knowledge-based systems that we were talking about earlier, where real understanding of how it is we make certain kinds of inferences, it might be that some systems are more explainable than others. You made a really good point, and the fact of the matter is most people have no idea what their doctor is doing, and when she says, I'm going to do this, they say, I trust you, we're done. On the other hand, we hope at least the doctor understands it. As sooner or later, there needs to be some sense that the people using a tool have at least a rough and ready understanding of how their tools work. You know, if when we come up with quantum computing, we're not entirely sure there's any human who can explain how there are certain phenomena in the world. But when it comes to healthcare and some of the intimacies involved in healthcare, it's reasonable to expect some basic level of understanding of how the tool works. What counts as a black box is not because someone's hiding it, it's because, well, it's more of a gray box. We could look inside all we want and still not be able to figure it out because we don't have the time that the machine had to make a billion mistakes to learn how the game is played. We do with knowledge-based systems have a better handle to, under the hood, if you will, to be able to say, here's the knowledge that was baked in, here's the way the algorithm was written, here's the way it produced the recommendation. Remember, in all of this, it might very well be blameworthy not to use one of these tools if there's good evidence that shows that you'll have a good outcome. And that's the tricky part. When our tools are better than humans, the relationship between the human and the tool becomes a little more complex.
Thank you. And Ken, can you just briefly summarize black box for some of us that may not know what it is?
Me or Ria?
Either. Ria, Ken, either. Just black box.
Yeah. The phrase black box has been used to describe machine learning models as sort of capturing their opaqueness, capturing the fact that if you pull apart machine learning models, the only thing you can infer about them is one, you can look at the code, and two, you can look at sort of the numbers. And I have whole opinions about, explaining what's in these models, and I won't get into them, but feel welcome to ask me, because I would argue that these things are not really black boxes. They're sort of boxes of spaghetti, and we can decide whether or not we really want to look into them and figure out exactly what the spaghetti is, like what is being constructed, is race being constructed? Like, we can do that. We shouldn't be, don't let yourself be easily convinced that these things are black boxes. And it's challenging. Older systems that have less perfect accuracy, which are some of the ones Ken's mentioning, they are not black box in the sense that every decision they make, they can point to a specific line of text or feature of your medical history to tell you why exactly this decision came out. They tend to be less accurate because they notice less fine-grained predictions about images, about language. So this is what I'll say about the myth of black boxes and the reality of black boxes.
Also, things get names very quickly, and we think the metaphor somehow is meaningful. Black box, if you try and explain black boxes and clouds and other sorts of ordinary words that we apply to technology, they catch, they stick. This is a sociological problem. How ordinary citizens in civil society acquire beliefs about things based on what they read in the news media or read online, when in fact, whatever captures our attention first ends up prevailing in ways that don't advance our understanding. And so then we have to take back the metaphors, if you will. But I think that's a really good example of it. It's a machine. I don't know how to explain how a carburetor works, but there are people who can, and I trust them to fix my car. And similarly, and I think this is your point, as long as even an autonomous system has some measure of governance going to your first or human control, then I think we can have some confidence moving forward that we might be able to get it right.
And I do think the question about how providers should be engaged with that is really interesting and perhaps not getting enough attention maybe it is, I don't know. But I think there's a lot of more, I feel like I see more about patients, but that could just be, that's what I read, than I see about providers. But I mean, I think there's lots of forms of technology that providers use that they may not fully, I mean, computers, how many providers know how a computer works, and they use a computer every single day for so much of their healthcare, and like, that's fine. I don't care if my doctor knows how the computer works, as long as they can with some degree of certainty navigate the EHR platform that was new and they're probably complaining about every day because it's destroying their life, right? And so I think that's the question, is how much do providers believe in this new technology? Do they trust it? How do they feel about potentially it taking away some of their authority? I think are really messy, complicated questions. Are providers willing to trust what a computer says over what they might see with their eyes or do with their hands? Are they willing to potentially have fewer jobs in certain areas? Like, do we need as many radiologists or as many pathologists if this can do better? There's been a lot of history of physicians not wanting to cede control, like even to other humans, let alone to, the self-checkout line, right, type thing. So I think figuring out how we engage providers and understanding what they want to understand, what they need to understand, their willingness to have less autonomy over decision-making, risk prediction, diagnostic, those seem to be things we should really be centering as well.
Yeah, I'll second parts of that. Yes, all right. And there's sort of, as you were saying before, like when you say explainable, there's sort of two questions. One is explainable to whom? And when you ask the question of, well, when does explainability matter? I'll say again, well, to whom? If there are, I might say that I tend to trust physical medication that's given to me at the doctor's office. There's lots of populations that historically have good reason to not trust that and want an explanation, right? And an explanation of well, who has this been tested on? Has it been tested? Has it been tested for my population, right? That's just different for different people. The same thing is true for machine learning models. There are cases in which maybe I'm personally okay with it, right? If you give me this beautiful machine learning model to create art with, I love it. I don't mind not spending that much time understanding. It's beautiful and exciting to me. There are places where, and I personally, and I don't think this is a thing people say, but I like critiquability as a word better than explainability, because I think that's what we care about, right? We don't care about, sometimes explainable systems actually make people have false trust in them more, right? When you say a system is explainable, there's all this evidence that people are actually more likely to trust it and agree with it, even when it is incorrect, right? So explainability is complicated, but you can ask, who is it critiquable to? And in what context do they want it to be critiquable by them?
Thank you. And just echoing that I wish we had more time. This is a wonderful, robust conversation. I know we perhaps had one more question that we didn't have enough time to be asked. So I encourage, if you have any additional questions, please feel free to reach out to anybody here at this table. I don't know if they're staying for the networking, but if they are, I encourage anyone to talk to us further. I'd also like to just say thank you so much to Ria, Jen, and Ken for your expertise, for all the work that you're doing, to everyone in the audience for having an interest in this subject, and just thank you so much for this panel. And a round of applause. Kudos. Thank you. And just a reminder that there is a talk coming up in this room and the West Poly Ballroom as well. So you're welcome to stay here for the next talk. Thank you so much.